So the first topic of discussion this evening is empowering cardio-renal metabolic outcomes in type 2 diabetes mellitus and the relevant place of SGLT2 inhibitors in the same regard. Now, before diving directly into the topic, let us have a few words regarding the background of this discussion. So we all know that type 2 diabetes mellitus is an absolute pandemic in the non-communicable disease category. In the year 2015 alone, there were 1.6 million deaths, most of it arising due to the notorious macrovascular complication, cardiovascular disease, and the equally notorious microvascular complication, chronic kidney disease. So blood glucose management is of paramount importance, but alongside the cardiovascular and kidney risk reduction ability of anti-diabetic agents would be a pertinent topic for discussion. Now, simultaneous with the exponential rise in new onset diabetics throughout the length and breadth of the country, there is an inordinate rise in cardiovascular disease. Now, the answer might lie partly in the unique phenotype, the Asian Indian phenotype or the so-called thin fat Indian phenotype, which is at the same BMI, we South Asians are likely to harbor greater visceral adiposity compared to any Western or Caucasian counterparts. Coupled with this increased insulin resistance and sedentary lifestyle and a carb-based diet, meaning greater postprandial blood glucose surges and oxidative stress, there is no prizes for guessing why cardiovascular diseases are on the rise in Indian subjects. This doesn't mean that every patient or majority of patients coming to your clinic would have a frank history of cardiovascular disease. In fact, it's on dedicated and specialized testing that you would pick up evidence of cardiovascular disease. However, this doesn't negate the fact that 1 in 3 patients with type 2 diabetes mellitus have some element of cardiovascular disease, predominantly subclinical, but which have equal relevance towards developing full-blown form in the next couple of years. The origin of cardiovascular disease in diabetes mellitus can be traced way back to the pre-diabetic stage, that is a period of IGT or impaired glucose tolerance, simply because of the fact that hyperinsulinemia rather than uncontrolled hyperglycemia might be an important risk factor for development of cardiovascular disease. So hyperinsulinemia uncontrolled might lead to the development of not only type 2 diabetes mellitus, but also non-alcoholic fatty liver disease and cardiovascular disease, a paradox seemingly explained by common soil theory. When we speak of cardiovascular disease in diabetes mellitus, we tend to indicate the development of only atherosclerotic cardiovascular disease. But the fact remains that the heart failure is a far more frequent complication than myocardial infarction or stroke, and the prognosis greatly worsened in the presence of diabetes mellitus. How does CKD fit this scenario? Now, type 2 diabetes mellitus is the sole leading cause of chronic kidney disease and end-stage kidney disease for the last couple of decades. And in a patient with type 2 diabetes mellitus and heart disease, CKD acts as a disease multiplier. And it is well known that CKD worsens cardiovascular disease and interestingly, vice versa, the phenomenon explained or encompassed by the terms cardio-renal syndromes. So we have seen that the diseases type 2 diabetes mellitus, atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease are interrelated, and the defects in metabolism and defects in pumps, filters, and pipes actually lie along the same risk continuum, and the coexistence of 2 or more of these entities lead to unfavorable cardio-metabolic outcome. So there was an urgent need for introducing a class of agents which, apart from meaningful blood glucose reduction, should also offer independent cardiorenal benefits. And a glimpse at this slide would clearly reveal that among the currently available anti-diabetic agents in our arsenal in the fight against diabetes mellitus, it's only SGLT2 inhibitors which are possibly armed with the maximum pleiotropic benefits or so-called extrapancreatic benefits, so much relevant in favorable modulation of kidney disease or cardiovascular disease. As an anti-diabetic agent, your primary job is to reduce the blood glucose, and this is served wonderfully by these classes of agents because SGLT2 inhibitors offer robust as well as durable glycemic control. And not only gliptins, SGLT2 inhibitors have also been found to offer greater efficacy in Asian Indian subjects. Now, if we recall that Asian Indian subjects are already at higher risk of development of cardiovascular disease and kidney disease, it makes stronger justification for earlier and aggressive usage of SGLT2 inhibitors for optimizing cardiometabolic outcome. Unexplained increase in micro and macrovascular complications in spite of maintenance of glycemic triad can often be attributed towards glycemic variability. And from CGM data, empagliflozin has been found to significantly improve the time in range. So maintenance of glycemic pented also apart from glycemic triad. Meaningful weight loss along with a reduction in visceral adiposity is a wonderful pleiotropic benefit of empagliflozin, or for that reason any SGLT2 inhibitors, because we might recall that visceral adiposity serves as an independent risk factor for cardiovascular disease. Insulin resistance not only forms the core pathophysiologic defect of type 2 diabetes mellitus, but it also leads to the development of non-alcoholic fatty liver disease and cardiovascular disease in type 2 diabetes mellitus. By reducing insulin resistance, which is done significantly by empagliflozin, it hits the core pathophysiologic defect of type 2 diabetes mellitus and alongside minimizes the risk of development of these comorbidities. Empagliflozin provides meaningful lowering in insulin requirement, and this is specifically relevant for Indian set of subjects who are terribly prick sensitive. Now, as I mentioned, non-alcoholic fatty liver disease is a pretty common but unfortunately underappreciated complication or comorbidity associated with type 2 diabetes mellitus, and it itself is a surrogate risk marker for future cardiovascular disease. Now, empagliflozin has been found to lower the hepatic fat content and improve the inflammatory activity in the liver. Like non-alcoholic fatty liver disease, obstructive sleep apnea by persistent sympathoadrenergic drive or increasing sympathoadrenergic activation leads to sudden cardiac death and progression of cardiovascular disease. Usage of empagliflozin theoretically and has been found in trials to reduce the risk of new onset OSA. Persistent nocturnal uncontrolled hypertension, that is reversal of normal dip in blood pressure, is a persistent nagging problem in type 2 diabetic patients with significant background insulin resistance, and this is taken care of wonderfully by empagliflozin. Empagliflozin not only stabilizes the eGFR decline, but also prevents the progression of albuminuria. Now, why is this significant? Because albuminuria or altered urinary albumin excretion, although typically a microvascular complication, it serves as a unifying point between microvascular complications and macrovascular complications in the form of cardiovascular disease and cerebrovascular disease. From the landmark empirical outcome study, and later on supported by meta-analysis, possibly the highest form of evidence, it has been found that empagliflozin provides holistic reduction in cardiovascular risk, incorporating hard clinical endpoints starting from 3-point major adverse cardiovascular events, cardiovascular death, and all-cause mortality. Now, empagliflozin has been found to reduce the risk of cardiovascular death irrespective of the underlying cardiovascular disease manifestation. Reduction in hospitalization for heart failure is another possible class effect of SGLT2 inhibitors, and it not only minimizes the morbidity and mortality in diabetic subjects, but it also minimizes the healthcare hospitalization related costs, which is particularly relevant for a third world country like India. Now, recent studies have shown that the benefits of SGLT2 inhibitors can also be extended to patients who did not have prior history of type 2 diabetes mellitus. That is, the cardio-renal benefits hold true even in patients without any history of dysglycemia. Again, underlining the fact that the Cardiorenal risk reduction is not a mere corollary of the blood glucose reduction. Many a times we have seen that an agent has shown wonderful benefits in controlled trial setting, but when the same agent is subjected to real world scenario, the benefits vanish altogether or show a significant blunting, but not with empagliflozin. When it's pitted against a gliptin, another wonderful agent in type 2 diabetes mellitus, it still shows consistent reduction in hospitalization for heart failure and mortality benefits and reduction in the risk of serious kidney events. Now, if not reduction in blood glucose, what played the trick in optimizing the cardiorenal outcome? We do not know for sure, but putatively it's a combination of hemodynamic benefits like reduction in central aortic pressure, improvement in endothelial relaxation, or unique metabolic benefits like increased glucagon and ketone bodies, alteration in cardiac myocardial energetics, which actually helped in optimizing the cardio-renal outcome. And in a first of its kind study, the IMPAHERT study, it provided tangible evidence that SGLT2 inhibitors, namely empagliflozin, might hit the structural defect in type 2 diabetes mellitus, because we all understand that left ventricular mass index is an independent risk marker for sudden cardiac death and precipitation of dangerous ventricular arrhythmias. Now, this volume of evidence have well been acknowledged by the global bodies responsible for advocating the standards of care throughout the world, like ENDIAB, who have categorically mentioned that for patients with indicators of atherosclerotic cardiovascular disease or chronic kidney disease or heart failure, consider SGLT2 inhibitors alongside metformin independent of baseline A1C to minimize the cardio-renal risk. The same idea has been echoed by the recent ACE guidelines. European Society of Cardiology possibly goes one step further and places empagliflozin even on top of metformin towards towards minimizing the cardiorenal risk in a patient with uncontrolled hyperglycemia and simultaneous high cardiovascular or chronic kidney disease risk. Whether we want to follow the ADA or the ESC guidelines, it depends upon the individual discretion, but these findings and these guidelines should be kept at the back of our mind. Now, the KDIGO, which is responsible for advocating the standards of care in the world of nephrology, have again toed the line of American Diabetes Association and mentioned that alongside diet and lifestyle modifications, SGLT2 inhibitors should be combined with metformin from the very beginning to prevent the further decline in eGFR, that is, stabilize the eGFR until and unless the original or the starting eGFR already precludes the use of SGLT2 inhibitors. Now, obviously, there would always be some subset of diabetic subpopulations in whom the risks outweigh benefits. So say, for example, those patients with significant structural defect of urinary tract or history of recurrent complicated UTI or frail elderly bedridden patients where the issue of hypovolemia is a real concern, or the eGFR already precluding the use of eGFR. Other than this minor subpopulation, most of the patients of type 2 diabetes mellitus who already have some element of subclinical cardiovascular disease or already at high risk of cardiovascular disease and chronic kidney disease stand to harness the benefits of this wonderful class of agents. So to summarize the last 15 minutes of discussion, cardio-renal metabolic risk progresses as a continuum in patients with type 2 diabetes mellitus and is best amenable to risk modification with SGLT2 inhibitors. And among the SGLT2 inhibitor class, empagliflozin particularly has demonstrated holistic 360-degree risk reduction for cardiovascular events involving hard clinical endpoints in landmark clinical trials and supported by meta-analysis in patients with type 2 diabetes mellitus and cardiovascular disease. Real-world evidence study also lends credence to these findings. So overall, we should optimize the clinical considerations of risk-benefit for each anti-diabetic therapy in the true principle of individualized approach for every patient. That is, individualized medicine is the need of the hour. Thank you for patient hearing.